A wound is rarely a simple cut. In clinical practice, evaluating physical trauma requires a precise 8-part diagnostic matrix to map exactly what tissue is damaged, how the injury occurred, and what pathogens are likely multiplying inside. The primary objective of this taxonomy is strictly predictive. It provides the mathematical probability of an infection developing and directly dictates the correct surgical intervention required to stop it. When a patient enters the trauma bay, the initial protocol involves analyzing 3 exact variables: the physical mechanism of the injury, the anatomical depth of tissue destruction, and the degree of bacterial contamination. Misjudge these variables, and a manageable injury rapidly evolves into deep space sepsis. Accurately plotting a wound on this matrix separates a predictable healing trajectory from catastrophic systemic failure. This diagram compares the physical cause of the insult. An incised wound produced by a sharp object, like a scalpel, leaves clean, regular edges with minimal adjacent tissue damage. Compare that to a laceration, where blunt force physically tears the skin apart, leaving highly irregular, ragged edges. This tearing action creates jagged connective tissue bridges across the gap. Because these crushed bridges have compromised blood supply, they serve as an ideal breeding ground for bacteria, ensuring the baseline infection risk for lacerations is significantly higher than clean incisions. You see this severe tissue destruction constantly in road traffic accidents. The high-energy blunt force trauma of a vehicle collision reliably produces these complex, heavily contaminated lacerations. Adjust the angle of the physical force, and the wound profile shifts. Friction across a rough surface shears off the superficial epidermis, causing an abrasion. If blunt trauma ruptures deep capillaries while the external skin remains intact, blood pools beneath the surface, forming a closed contusion. Puncture wounds present an entirely different physiological threat. A pointed object creates a tiny external opening, but penetrates deeply, making the wound tract nearly impossible to clean. This drives pathogens directly into deep tissue, carrying severe risks for bone infections like osteomyelitis, tetanus, and fast-spreading anaerobic bacteria. If a foreign object enters a body cavity, it becomes a penetrating wound. If that object has sufficient energy to travel completely through the body and create an exit wound on the other side, it is classified as a perforating wound. These perforating injuries are almost exclusively the result of high-velocity projectiles like bullets, causing massive secondary cavitation damage to deep internal organs. Extreme mechanical forces produce avulsions, where tissue is forcibly detached, leaving the remaining structures with severely compromised blood supply. Alternatively, heavy compressive forces produce crush wounds, triggering extreme muscle damage and fluid buildup that easily leads to compartment syndrome. Industrial environments and heavy machinery accidents are the primary settings for both mechanisms. Workers frequently sustain severe degloving avulsions, or crush injuries, that release massive amounts of toxic muscle proteins into the bloodstream, causing rhabdomyolysis. Bite wounds require their own specific microbiology protocols. Human bites carry the highest overall infection rate due to concentrated mixed aerobic and anaerobic bacteria in the mouth. Animal bites introduce completely different pathogens. Dog and cat injuries require immediate prophylaxis for rabies and Pasteurella infections. Not all tissue damage requires physical impact. Etiologies also thermal extremes, chemical acid or alkali exposures, and ionizing radiation destroying cellular regeneration. High-voltage electrical injuries, including lightning strikes, are particularly deceptive. The current causes extensive deep muscle necrosis and can trigger fatal cardiac arrhythmias instantly. By strictly identifying the exact etiology and mechanism of the insult from arrival, clinicians can map out these specific pathological complications before they appear on the patient's vitals monitor. This model illustrates the Z-axis of a wound, anatomical depth. The deeper the injury penetrates through the epidermis, dermis, subcutaneous fat, muscle, and bone, the more structural reconstruction is required. Superficial wounds, like minor abrasions, isolate the cellular destruction entirely to the uppermost layer, the epidermis. Partial thickness wounds extend further into the dermis. Even with this damage, structures like hair follicles remain intact, allowing the tissue to heal independently via epithelial regeneration. Full-thickness wounds represent complete loss of the entire skin structure, exposing the underlying subcutaneous fat. Independent regeneration is impossible here. These defects mandate surgical suturing or skin grafting to close. Deep wounds breach the fat layer entirely, compromising highly vascularized muscle, severing tendons and major nerves, fracturing bone, or exposing internal visceral organs. Recognizing anatomical depth immediately dictates the geometry of the repair. Sealing a deep wound without thoroughly cleaning the underlying layers creates a closed anaerobic cavity, virtually ensuring a deep space infection. To quantify the probability of that infection, hospitals rely on the CDC Surgical Wound Classification System. This grid acts as the definitive mathematical metric for forecasting post-operative surgical site infections based on bacterial burden. Class 1 designates clean wounds. These exhibit zero acute inflammation, and the surgeon does not enter the respiratory, gastrointestinal, biliary, or genitourinary tracts. The infection risk remains strictly under 2%. Standard, highly controlled elective procedures like hernia repairs or thyroidectomies fall strictly into this category, minimizing the introduction of outside pathogens. Class 2, or clean contaminated, involves controlled entry into those exact tracts, respiratory, GI, biliary, or GU, under sterile conditions without any unusual spillage. The expected infection risk climbs to between 5 and 10%. Class 3 designates contaminated wounds. This occurs with fresh traumatic injuries, instances of gross GI spillage like a ruptured bowel, or a major break in sterile surgical technique. Here, the probability of infection jumps to 15 to 20%. Finally, Class 4 outlines dirty or infected wounds. These involve old trauma, devitalized necrotic tissue, existing purulence, or a perforated viscus like a burst of hence. Preoperative bacterial load using these 4 classes dictates the next critical surgical decision, whether the surgeon can safely close the wound or if it must be left open. We must also measure the dimension of duration. Acute wounds follow a predictable biological timeline, while chronic wounds like diabetic or venous ulcers fail to progress after 4 to 6 weeks due to severe physiological impairments. By calculating the duration alongside mechanism, depth, and the CDC contamination class, a surgeon selects one of 3 specific pathways for healing. The first pathway is primary intention. Utilized exclusively for clean, Class 1 wounds, the surgeon immediately approximates the edges with sutures. It heals rapidly with a minimal scar. The second is secondary intention. In cases of major tissue loss or high infection risk, the wound is left open. It heals by slowly filling the defect from the base upward with red granulation tissue, resulting in prominent wound contraction. The final pathway is tertiary intention, or delayed primary closure. The defect is intentionally left open for 3 to 5 days to allow the surgical team to clear heavy contamination. It is only sutured closed once the active infection is neutralized. Forcing primary closure on a highly contaminated wound traps bacteria under the skin, guaranteeing an abscess. Opting for secondary or tertiary intention is an active, mandatory protective surgical strategy deployed specifically to guard against catastrophic systemic infection. In clinical practice, these classifications do not exist in isolation. A surgeon evaluates all 8 taxonomic axes simultaneously, routing the variables through a decision tree to determine the ultimate complexity of the injury. Injuries that isolate damage to a single tissue layer without severing any major vessels or nerves are categorized as simple wounds. Their geometry is straightforward, safely permitting immediate primary closure. By contrast, multifaceted traumas featuring major tissue loss, exposed bone, or severe neurovascular injury graduate strictly to the level of complex wounds. If we input a crush injury extending into the deep layer with Class 3 contamination, the algorithm aggressively blocks any attempt at primary closure. It routes the surgeon directly towards tertiary intention and extensive reconstruction. Because these complex traumas carry massive bacterial loads and compromised tissue, they require a multidisciplinary surgical approach to aggressively debride devitalized cells and manage organ-threatening complications. A trauma bay can appear chaotic, but the underlying logic remains strict. By filtering a physical insult through this encyclopedic diagnostic framework, medical professionals calculate exact pathological risks, control the environment, and establish a predictable surgical outcome.